Most recently, she served on the Testing and Diagnostics Subcommittee of the HHS Tick-Borne Disease Working Group, which delivered its first report to Congress in 2018. Welcome, Holly Ahern.
Okay, who said that? The voice of God. More things. So I am from upstate New York. I am here because a few years back, my beautiful daughter, who was here but I think has gone to get me coffee, developed a case of a mysterious illness, just like so many other people, that was very difficult to diagnose, and unfortunately it was diagnosed late into the infectious disease. And so the journey that my family took to get to this point was torturous, and I decided that, once she was well enough to concentrate on other things, that I really needed to do something to try to change the landscape. And so, years into this, we have, I am actually the co-founder and vice president of an advocacy organization, Lyme Action Network, on the East Coast, and also the scientific advisor for Focus on Lyme, and I think we are changing the landscape for the better. So with that, what I want to talk about a little bit is something that we at Focus on Lyme, and actually just in general, have recognized as one of the major problems with Lyme disease, which is the lack of a good diagnostic test. So just to give you an overview of the scope of the situation, in 2017, the CDC, which tracks the numbers of infectious diseases in the country, reported that there were over 400,000 new cases of Lyme disease that are reported annually. And actually that number is over 427,000, and that is just an estimate because there are several states that don't actually count cases because their county health departments are so overwhelmed with the number of cases that they don't keep track of them. So they estimate them. And the CDC does not even incorporate state data when that is the case. So here's the problem. Although there are 400,000 new cases of Lyme disease that occur in a year, is this working? There we go. The actual problem is that a significant proportion of those people will actually develop a chronic debilitating illness. And the medical construct of Lyme disease is that it is a disease that's hard to catch and easy to cure. And so until we get better recognition of the chronic state of the disease, this is where the problem is going to lie. So I just want to point out for the numbers what this means in terms of public health impact of this disease. So assuming, there are 400,000 new cases per year, this is going up, all right, but we'll use that to make the math simple. And something like 60%, and you'll see where those numbers come from in a second, will develop a chronic illness as a result of that. So notice what happens to the number. Of the 400,000 new cases of Lyme disease that occurred in 2018, 240,000 of those individuals will develop chronic illness. And then add 240,000 every year, and in 5 years you can see that that rapidly escalates to over $1.2 million, that's billions of dollars, right? 1.2 million cases of chronic illness that can be directly attributed to Lyme disease or tick-borne illnesses, okay? And by that I mean, chronic illnesses that are not just Lyme disease, but are multifactorial, as we indicated. So I just have kind of a pop quiz question for you. 427,000 new cases of Lyme disease a year. Do you have any idea what that means in terms of all the infectious diseases that occur in the United States? Okay, so all of them. There are 80 that are tracked by the CDC. Where does 427,000 new cases put Lyme disease in terms of the most popular infectious diseases? Anybody have any ideas? What number one? What do you think is the most popular infectious disease in the United States? Anybody want to guess? HIV? Nope, not even close. Not even on the top 10, actually, anymore. Epstein-Barr. Epstein-Barr? Nope.
Lyme disease.
Good guess, but it's not Lyme. It's chlamydia. Yes, sexually transmitted chlamydia is the most popular infectious disease. I think it's probably easy to figure out why that would be. But Lyme disease is number 2. Number 2 in the United States. It's the second most common infectious disease, and yet it is treated like it is a simple public health problem that doesn't require additional time and attention, which is false. So I was also a member of one of the subcommittees of the HHS Tick-Borne Disease Working Group. I was on the Testing and Diagnostic Subcommittee. I just want to, this report, by the way, is public. You can go download it. You can read it yourself. You can read the entire report. But what I urge you to do is to read the subcommittee reports, because each subcommittee was assigned the task of doing a deep dive into the scientific literature, medical problems, listening to speakers come and talk and discuss the problem, and then identifying the gaps. And the entire report kind of lays out what the gaps are and makes recommendations, but the subcommittee reports are the work of the subcommittees themselves. It includes all the research that went into it. It included the opinions and recommendations of that subcommittee. The whole report is a compilation of that whole thing. So if you're interested in finding out what the views of the scientists were, read the subcommittee reports. So from the larger report, these were gaps that were identified in 3 areas: prevention, testing, diagnostics and testing, and treatment. Those were the 3 areas where major gaps were noted. Those gaps are obviously our existing prevention methods are failing us, and we know that because it is the second most popular infectious disease in the United States, and that also worldwide, I might add, so that this is not a United States problem. Our existing diagnostic tests are not clinically accurate, and what that means is you are equally likely to have Lyme disease whether your diagnostic test, your serology 2-tier test, came back positive or negative. Let that sink in. You are equally likely to have this disease regardless of the outcome of your test. That is ridiculous. So what they focus on are false positives because, God forbid, you get treated with antibiotics that are unnecessary, like the 2 people that occurs to. The far bigger problem is false negative laboratory tests. So what that actually means is when you try to pare down what the situation is with regard to the testing, at this point in time, but before you can come up with solutions, you have to decide what the problem is. So we decided at Focus on Lyme, and actually, we've been working on this for a long time, this is the problem. So at the present time, using the diagnostic criteria for Lyme disease, only one subgroup can be accurately diagnosed. Those whose disease started with a typical classic bullseye appearing rash called an erythema migrans rash. Because if you are the lucky winner of that rash, and by the way, your doctor knows how to identify it, then you will get diagnosed with Lyme disease. You will receive treatment for that rash, which usually occurs sort of early on in the infection. But if you are outside of that group, then you will probably not get that diagnosis. And as a result, the bacteria disseminate through the blood to tissues where they form biofilms and establish permanent chronic disease that is due to chronic inflammation, right? Because the bacteria know, your immune system knows the bacteria are there, but they can't get rid of it. So this is the diagnostic algorithm for Lyme disease. I borrowed this from the website of a family practice medical society. So this is to make the decision as to whether you have Lyme disease or not, unless you are a physician who is involved in integrative medicine or looks more closely at these sorts of things. This is what you are recommended to look at. So notice this is an algorithm. Okay, now this is not, there are other diseases that require algorithms for diagnosis. This is just one of them. But what I want to do is to point out why it's practically impossible for a physician who is following medical guidelines to diagnose somebody correctly with Lyme disease. So starting with the criteria of, is Lyme disease suspected? So when is Lyme disease suspected? It is suspected if you happen to live in a Lyme endemic region, which would be the Northeast, a little blob up in the upper Midwest, and a few places in California. Those are the endemic areas. You have a known tick bite, and it is the right season, meaning somewhere between May and July. We'll make it widespread there. So because I have a lovely cohort here that I can do a research study on, let me just ask you, so how many people, based on your own case, would fall into the Lyme disease was suspected when you went to your doctor because you live in a Lyme endemic region? Northeast, Upper Midwest, California. Okay, so we got 3, 4, 5. My daughter's one of them too, so 6 out of the room. Oh, Kaylee, raise your hand. That's my daughter, by the way, okay. You made the wrong time to walk in. So how many of you remember the tick bite? Of those of you that were in the right place, how many of you, 6 people, remember the tick bite? All right, 2. And then how many of you were in the right season to have that tick bite? So how many of you remember if that tick bite occurred in May, for example, or early June? All right, so that means all of you were ruled out from the diagnosis of Lyme disease just based on that. So the physician would not suspect Lyme disease. The second criteria, so in other words, if you happen to have those things, so if you were in a Lyme endemic region, and I have to say New York State is doing pretty good when it comes to saying, all right, is there a bullseye rash or not? Looking for the EM rash is the #1 criteria, right? So if you are the lucky winner of this rash, you're diagnosed with Lyme disease, it is considered to be early in the infection, which is about half true because you can also get EM rashes long after you've been infected when the bacteria reactivate. If you are diagnosed with that, just to point out that this is not a very good disease marker. So how many of you remember, anybody in the room, now it'll just open back up to the whole cohort, remember the EM rash? How many of you actually your disease started with a bullseye rash? 2? 3? 3 people. So all the rest of you are ruled out from the diagnosis of Lyme disease. Notice that the true rate of the rash, this is observed in non-human primate models. This is observed in human studies of the disease, that the true bullseye rash occurs in less than 10% of patients, the true target-shaped bullseye rash. In other cases, there is a rash, but it is a solid raised rash that looks like a bug bite, a spider bite, or some other bite, which may or may not be interpreted because the criteria says it has to be a bullseye or it isn't a Lyme disease rash. So basically, those 2 things are the reason why so many people are not diagnosed early in the infectious disease. If you do, what you are offered is 3 weeks of an antibiotic. The antibiotic is usually doxycycline. The scary part about that is the research that we're hearing from everybody is that doxycycline actually drives the bacteria into that persister state. It encourages them to stick around, if you will. So that is actually kind of scary because that is the frontline treatment for Lyme disease. And at the moment, that is the only recommended treatment for Lyme disease. Medically recommended, that's what I'm talking about. So these are based on medical guidelines. And I want to add to that, that even if you get the bullseye rash, get the 3 weeks of doxycycline, the rash goes away, 10 to 20% of those patients who are early diagnosed, early treated, still develop chronic disease. So that is a subgroup that is called post-treatment Lyme disease syndrome. It's abbreviated PTLDS. I have to say that most chronic disease patients are kind of lumped into this category. I'm not, and it's probably the same overall reasons why people end up with post-treatment Lyme disease syndrome as end up with other cases. But the argument about post-treatment is it's post-treatment, meaning the treatment killed the bacteria. You have some post-infection kind of thing going on. And so it excludes the possibility that there is an infectious process going on. And therefore, what to do about this, whether to treat with more antibiotics, whether to not treat with more antibiotics. And it's not just a medical decision anymore because your insurance company probably will not pay for additional treatments once you've had this 3 weeks of antibiotics. And they won't treat because of the fact that the next stage of this process is to do a test called an ELISA test. The ELISA is wrong half the time. for many reasons, not the least of which is that your immune system is being tricked by the bacteria, number one. Number two, the antibody levels, if they happen to occur, don't occur for 4 to 6 weeks. So in other words, if you go with a tick bite or even with a rash and you have a blood test, the blood test is negative, your doctor's going to believe the blood test result before the doctor will believe anything else, because that is record keeping that doctors want to keep. They want to say, see, here is clinical evidence, here's laboratory evidence that this person has an infection. But that blood test, that's the reason why this blood test is wrong half the time, that you are equally likely to have Lyme disease whether your test is positive or negative. And here's what happens. If the blood test isn't, if you don't have the rash, you have symptoms, the blood test is done, the blood test is negative, here's what the bacteria are doing while the rest of the process goes around. So what the physician will do is think about it a little bit, scratch their heads, wait 6 to 12 weeks. And during those 6 to 12 weeks, which may be even more because you may give up and stop going back to the doctor, antibiotic treatment may be delayed for months to years. The bacteria disseminate, establish their permanent biofilms, go on to cause chronic inflammation. The inflammation is driving your symptoms, but the doctors will look at the symptoms and just say that can't possibly be infection because your blood test was actually negative. It is a perfect catch-22. How do you solve this? So that if you follow the algorithm, actually I should probably point here, okay, so if you follow the algorithm through this process, notice it all leads back, you wait 6 to 12 weeks, it all leads back to doing another ELISA test, which is still equally likely to be wrong. And then you offer a Western blot, which is the more specific kind of test that goes along with that. If you get a positive result, yes, you have Lyme disease and you get treated with another 3 weeks of antibiotics at that point, even though you've had the infection for 6 years. And at that point, 3 weeks of doxycycline is going to do exactly what Garth said it's going to do, which is just basically, I love that cartoon, by the way, laugh at you. So from this point, we can define a third subgroup. So this is a distinct subgroup from post-treatment Lyme disease syndrome. I'm calling it subgroup 3 because it is the most contentious group of all Lyme disease patients. I believe it probably applies to most of you. And that would be 30 to 40%. And by the way, that statistic comes from a research article published in 1982 by Dr. Alan Steer, where he did the first clinical trials of antibiotics against Lyme disease. And what he found were 42% of patients failed his 2 weeks of antibiotic trial. And what he did was say, well, that can't possibly be right because that can't possibly be right. So he changed the symptoms. So he said, those of you with headaches, migrating joint pain, those other non-specific symptoms, neurological symptoms, you guys, those are minor symptoms. Now, if you get another bullseye rash, or if you end up in the hospital with meningitis, that if we do a spinal tap, we can find the spirochetes in, now that's failure. That means you still have that infection. That was 2% of the population. The article concluded, no problem, right? 2% fail antibiotic treatment, this is great, but 42% of his patients failed that antibiotic treatment. So that's why I feel safe that I can use that as a statistic. So another 30 to 40% of those people who are diagnosed and treated late in the infection are going to end up with a chronic illness. Those are the symptoms on the IMSIDS scale right there. And then, of course, there's this, which is the idea that the IgM, okay, so any docs here will say, oh, if I have a positive IgM, what does that mean? Doc, what does it mean if you have a positive IgM? In a classic interpretation of the immune response, it means or early infection within the first month. And we heard this yesterday, we heard this today, that chronic Lyme disease patients have an IgM response. But what will happen is, this is, this has been going on for a while, we're talking years, you can't possibly have a positive IgM response, it must be a false positive. And I can't tell you how many people tell me, come up and show me their blood test results, positive across the board for their IgM antibodies, and are told this is a false positive test result, you don't have Lyme disease. That is false. And our research has shown that. We got to get the word out in a bigger way. because IgM is a positive result, or should be interpreted as a positive result. But without it, so you have a false positive test, it's therefore really negative, so you have something else. You have MS, you have ALS, you have epilepsy, you have mental illness, you need to go to a specialist, you need to go someplace else. Once you're out of that realm and into the realm of autoimmune, that's it. Anybody depressed? I hope not. This is the reality that chronic Lyme disease patients go through. And it all goes back to the fact that if you don't have the bullseye rash, you don't have a chance of getting a diagnosis until it is really antibiotics are not going to be, straightforward antibiotics are not going to be entirely successful. So to further define the problem, treatment failure, which is what that is, leads to chronic illness. So 10 to 20% of those people are going to develop post-treatment Lyme disease syndrome. And what you see is a study published by Dr. John Alcott at Johns Hopkins University showing what he calls a well-defined group of patients. So he has defined post-treatment Lyme disease syndrome in a way that says, starting from the beginning and going on, he's defined what that actually means. So we do have a definition, although it's not widely accepted yet, of what that post-treatment group, the 10 to 20% of treated, early diagnosed and treated patients, and realize that 60 to 90%, therefore, are not going to be diagnosed for weeks, months, or years, and will develop chronic symptoms as a result. And this is Dr. Horowitz's paper, which he showed you earlier, which just basically says this is a very debilitating disease. The 42% of affected individuals report that they had to stop work. They had to stop going to school. They have to take care of family members who are so severely afflicted, they have no other options but to do that. That is a profound human health impact. It is a public health issue that needs to be addressed, and hopefully it will be. So I have to point this out. I don't really need to, but I want to, that this is a real disease. It is real. And we now have the scientific evidence showing us what's going on. So in research that is done with non-human primates, which is the best model of this disease there is, because the kinds of experiments that you can do with non-human primates, you cannot do on humans. So, but they respond exactly the same way that humans do to infection. So it's a perfect model to find out, look at the natural course of the illness, look at treatments to see what works and what doesn't. And so that is research that is being done by Dr. Monica Embers, who I think was here, but are you here, Dr. Monica Embers? Oh, she just left, of course she did. Who talked about this yesterday. And her research is really leading the way, groundbreaking, to answers to these problems, because she's able to show what happens with the course of the disease. And just also to point out that it's true that the major symptoms are due to chronic inflammation. Chronic inflammation in the brain leads to what, the technical thing is glial cell activation, but what in this article, what they used were PET scans to look at what's happening in the brain of Lyme disease patients, the post-treatment Lyme disease group. It is widespread inflammation in several areas of the brain. The inflammation is what's causing those neurological symptoms. Realize that your brain impacts your entire body, right? Different parts of your brain do different things. Some of it helps you think, and other parts of it help your body do what it has to do. That's what's being impacted by neurological Lyme disease. And then also recently, this was within just the past couple of weeks as well, that 10 out of 10 patients with post-treatment Lyme disease syndrome showed small fiber neuropathy. So that is what Dr. Horowitz was referring to as autonomic nervous system. They're showing that this is also part of that overall process. So the evidence is building. It's becoming, too large to resist, and hopefully that will, turn the tide sooner rather than later. So I hope you can see, if we could go back and stop this from happening, then the whole issue of chronic illness would actually go away. But before we can do that, we have to be able to determine who actually does have the disease and who doesn't. We have no way of doing that now because the tests are so inaccurate. And so this is a table that came from the HHS subcommittee report, where one of the things we did was to explore all of the technologies that were currently available that could be repurposed quickly and translate into a diagnostic test. And a focus on Lyme, we have been trying to work through these to find a test, an accurate diagnostic that, again, will be translated quickly into patient space. So it'll be a test that you'll be able to go to your family practice physician. They will know how to order it. They will be able to draw the blood sample, send it off to a laboratory where they'll have a small machine that will do that and give you a positive or negative result. So you can go with the tick bite and know within a day of that tick bite whether you are infected or not, and then initiate early antibiotic treatment. What those treatments are, we obviously still need work on that, but that's our goal at Focus on Lyme. And so, having sorted through many of these different things, multiplex amplicon sequencing, culture-based methods, all of which are very time-consuming, right? Direct diagnostics are important because we want to show that the bacteria are present, which you'll be hearing more about ways to do that coming up. But there are two, that I put the little stars on there, transcriptomics and microfluidics, or immunosignatures, are very, very promising because they are small-scaled. You can put the interface on chips, and all you need is a small reader device that will allow you to read those results. In other words, it can go into LabCorp or another laboratory. They'll know that it will not require specialized training of people to do DNA sequencing, for example. It'll be a test that will work pretty well. And so what we're trying to do here is say yes to the test, right? So we're sorting through those. I think we're close. We might have to come back another time or two to do this. But here's what we need. The test we want to say yes to, and then once that happens, we are all in. We're going to make that happen. We're going to translate it to the patient space. You'll make your head spin. It'll come out so fast, right? So what we need a test that's going to be positive shortly after you are infected, because at this point in time, that remains the best option to prevent people from developing chronic disease, is to find a test that works early, find one that works late, so you won't get those false negative tests or the true positive tests that will be interpreted as false negative tests. We need one that identifies the comorbid infections, which would include Bartonella and Babesia at least, but you saw Dr. Horowitz show you that so many of his patients have a wide range of other illnesses that will also need to be on this platform. And we need to know when to stop. So whatever the test is, it needs to change to something else like gone, so that you can monitor treatment outcomes and know when it's time to stop or to try something else. So that is what our overall goal is for Focus on Lyme. And so I hope that gives you some hope for that, because once it's clear what your first problem is, then there can be treatments designed to come up with that. What I'm talking about is once we know who has and who does not, we can actually design clinical trials of things based on knowing that you have Lyme disease and Bartonella and Babesia, as opposed to just Bartonella or just Lyme disease or something else entirely. So thank you all for coming, and I think I have finished there, yes.